So hello everybody. So my name is Sebastian RIMBERT, and actually I'm a postdoctoral student in the Potiok team in RIA Bordeaux with Fabien Lotte, and I'm working in the ERC Brain Conquest project. And today I'm very happy to present you the work I've done during my thesis, but also after my defense. And this work particularly investigates how to improving BCI users' performances with a new kind of BCI, a BCI based on median nerve stimulation. So during my thesis, I was interested to prevent a creepy phenomenon called intraoperative awareness, and I proposed to use this kind of BCI based on median nerve stimulation to detect it. And after this example of application, we will see that the BCI based on median nerve stimulation could be used for other applications like stroke rehabilitation or BCI control. So first of all, what is an intraoperative awareness? So I agree, this picture is totally creepy, but an intraoperative awareness is an unexpected awakening of the patient during a surgical procedure under general anesthesia. And in practice, the patient is awake and could memorize the event, can feel some pain, and understand what's happening to him. And if we look the occurrence of intraoperative awareness, we can say that apparently there are not a lot, 0.1%, 0.2% in general practice. But if we look in some high-risk practice, we have up to 1% of intraoperative awareness cases. And considering the high number of practice around the world, it means that 200,000 people are living this traumatic experience per year. So it's a lot. So what about the consequence for the patient? So the main problem is after this terrific experience, this leads to post-traumatic stress disorder or PTSD. And that implies an increased risk of suicide for the patient. And we also know that in America, for example, most of the legal attacks come from intraoperative awareness cases. So it's a big challenge for the hospital to better monitoring general anesthesia. And to do that, to better monitoring general anesthesia, actually there are two ways. First, we can observe clinical features like heart rate, blood pressure, temperature, and movement, but in the most of cases of intraoperative awareness, the physical constant remains unchanged. And the second way is to use cerebral activity, for example, with the EEG technique, and some devices already exist in hospitals like the bispectral index or entropy, and you can see it on this figure. And mainly in measuring the frontal cortex activity. Concretely, it's an index between 0 and 100, and 0 represents when the patient is awake, and 100 when the patient is unconscious. But the problem with this kind of device is several studies have shown the vulnerability of this technique. And when we talk with anesthesiologists on medical stuff, they tell us stories, terrific stories about patients who were awake, but the bispectral index indicated that they were unconscious. So we have to find another way to detect the intraoperative awareness. And in my thesis, we were particularly interested by testimonies of patients. The first reaction of a patient in this situation is that they want to inform the medical staff to show that they are awake. And to do that, they try to move their bodies, move their arm, move their feet. And the problem is that they can't do it because they have previously received the neuromuscular blockers who permit the general anesthesia. So the situation is like this. The patient wakes up during the operation, but nobody knows anything about it. He tries to move to warn the medical staff, but it's impossible. So the question is, can we detect its intention of movement with a brain-computer interface? And for now, in the BCI domain, you know that we can distinguish the intention of movement in classifying resting state versus motor imagery. So in theory, it's possible, but in practice, it's more complicated. It's more complicated because we have two main challenges. The first challenge is it's necessary to detect the intention of movement for the patient without any time marker, because it won't be possible to know when the patient will try to move. We won't have any cue to know each time window to analyze with the BCI. And it's a problem because the literature clearly shows that the classification rate decreases when you want to do an asynchronous BCI. The second challenge is that we have to find a way to have a high level of accuracy if you want to use the BCI in a medical context during a clinical routine. We have to be sure that the subject is conscious or not. And unfortunately, we know that the accuracy obtained for example, motor imagery versus resting state remains low and should be improved. And a second point is that the results are very variable from one subject to another, and especially from one experiment to another. So what we propose in a recent article published in Frontiers in Neuroscience is to use a BCI based on median nerve stimulation. So in fact, the concept is quite simple. It is known that a motor task, such as a real movement, an attempt movement, or intentional movement, produce what is called an event-related desynchronization, or ERD. You can see it in blue, and this ERD appears in the mu and beta band, which is present during all the motor tasks. And after that, we have an event-related synchronization, or ERS, in red, and it appears mainly in the beta band, and it's called rebound, but also present in the mu band. And we also know that when we stimulate the median nerve, which is located between the two tendons just there, it will cause a micro movement between the thumb and the index finger like that. And at the brain level, we will also have a very short ERD because the stimulation is very discrete, followed by an ERS. And that happens with very low stimulation that is not painful for the subject. It's between 5 and 15 microampere. And it's not painful, I tested. What is very interesting is to know what happens if you stimulate the median nerve of a subject when he is doing a motor task. And several previous studies has investigated this question and shows that there is a modification of the ERS. Sometimes the rebound disappears, sometimes it only decreases. And it's logical because the ERD from the motor imagery want to exist in the same time that the ERS produced by the median nerve stimulation. And the result is a decrease of the ERS. In our article, we verified this abolition of beta rebound during the median nerve stimulation with motor imagery. And we showed that a classifier based on median nerve stimulation is better than a standard BCI, for example, with motor imagery versus resting state. And we have 18% improvement with the MNS-based BCI. So this work suggests that median nerve stimulation could be used to detect intraoperative awareness. In theory, we can imagine a brain-computer interface that will stimulate the median nerves of the patient every 3 or 4 seconds and look at what is happening after each stimulation in terms of ERD and DRS. And if the patient is conscious, brain activity in the motor cortex will change and the ERS will be modified or disappear. So if we can imagine designing this kind of BCI based on median nerve stimulation, 2 questions are relevant. The first one is how the anesthetics will influence the EEG signal over the motor cortex. We have seen that median nerve stimulation on motor imagery generated specific ERD and DRS, but we don't know if the propofol, the common anesthetic used for general anesthesia, will not change ERD and DRS modulation. And the second one is, will anesthesia have an effect on classification? Because if ERD and DRS were modified by the propofol, maybe the performance based on the median nerve stimulation will be bad. So to respond to those 2 questions, we are conducting an experiment with volunteers at the Nancy Hospital in France, and we collaborate with the anesthesiologist in the hospital. And during this study, the subject have to perform several motor tasks at different concentration of propofol, so the anesthetic commonly used, but we stay just below the concentration that will cause loss of consciousness, because if there is a loss of consciousness, it's impossible to know if the subject is performing the motor task, and especially for motor imagery. So we had 3 concentrations, 0, 0.5, and 1 microgram of propofol, and we know that in surgical condition, people start to lose consciousness from 1.5 and 2, but we could have some variation between subjects. And we studied 4 motor tasks: real movement, motor imagery, median nerve stimulation alone, and median nerve stimulation during a motor imagery. And this experiment were in eyes closed condition, and we previously verified that ERD modulation in eyes closed condition were detectable by a BCI. So here is an example of a volunteer in a medical intensive care unit. The participant has a pointer in his hand, and he has to imagine to press it. He is equipped with a biosemi EEG cap, and he is equipped with a median nerve stimulator from Micromed. And at the moment, we have 15 subjects recorded, and because of the COVID, the experiments have been stopped, but will start again soon. So concerning the result, we compute event-related spectral perturbation with the EEG Lab toolbox for the 15 subjects, and ERSP are very similar to ERD and DRS method from Forscheller. It's just a computation of the power in different frequency band and times. So for the median nerve stimulation conditions, the results are very consistent with the result I showed previously. We have an ERD just after the stimulation, following by an ERS. And about the effect of propofol, the result shows that ERD and ERS are still present for 1 microgram per millimeter of propofol. And we have to note that the ERS seems to increase for the 0.5 concentration and decrease a little bit for 1 microgram of propofol. So now for the median nerve stimulation on motor imagery condition, we can see that the ERD seems to inhibit the ERS. We have only ERD and the ERS disappear between the two ERD. And it's the case for all the propofol concentration. So it's a good news to be able to discriminate these two states. So now we have previously seen that median nerve stimulation can be useful to detect intraoperative awareness. But now the question is, can we use this kind of BCI for other applications, such as rehabilitation after stroke or BCI control or sport training? So because the issues addressed by this BCI for detecting intraoperative awareness are also important issues for other applications, I'm thinking about increasing BCI performance in detection, for example. So the second question is, how can this BCI could be implemented? In terms of frequency band, in terms of time window, we have to choose before and after the median nerve stimulation, and the electrode we have to use. So to answer this question, several existing databases were used and combined to create a new database of 52 subjects with 3 conditions. So one with motor imagery alone, another one with median nerve stimulation alone, and another one with median nerve stimulation during motor imagery. And what we get in terms of topographic result is this type of figure. So on this figure, you can see at the left the motor imagery on MNS median nerve stimulation condition, and at right the median nerve stimulation alone. So I can repeat. Okay. So first of all, there is only motor imagery. So at the left, you can see an ERD on the contralateral side because it's a right-hand motor imagery. And the ERD is strong at the contralateral side. And after that, there is a median nerve stimulation for both conditions just now. And you can see an ERS at right and a bilateral ERD at left. So it means that the ERD hits the ERS from median nerve stimulation. And you can easily see that it's easy for the BCI to discriminate those two states. And after that, you have a stronger ERS for the median nerve stimulation condition. So we also compared the performance of a standard BCI, so motor imagery versus resting state, with the performance of a BCI based on median nerve stimulation, depending on the classifier used. So we use 4 types of classifier, common spatial pattern on LDA, but also Riemannian geometry with tangent space and logistic regression, for example. And you can see that we have an improvement on 21% in average for median nerve stimulation-based BCI. We also look at which time window to take before, during, and after the stimulation to have a better performance. What we observe is that the time window taken just before and after the stimulation during 3 seconds give us better results. And finally, concerning the frequency bands to be used, median nerve stimulation generated ERS mainly in the beta band, while motor imagery produced ERD modulation mainly in the mu band. So it seemed interesting to use the 8 to 30 Hz window to have the better result. And the gamma band is not useful because the stimulation doesn't generate ERS in the gamma band. So to conclude, we have seen that the BCI based on median nerve stimulation could be appropriate to detect intraoperative awareness, even in presence of propofol, but we have to do a lot of experiments in high dose of propofol, and we have to do that in next month. And finally, median nerve stimulation could also be used in a more general framework in BCI, because this would allow the detection of a motor imagery without an EQ and with a better accuracy, around 20% of improvement. To finish, I would like to say thank you to all my collaborators on this project, Laurent Bougrain, my previous supervisor, all the anesthesiologists from the hospital, and my actual supervisor, Fabien Lotte. Thank you for your attention, and if you have any question, I will be happy to respond.